Hello, this is Dr. Philip May. I'll be talking with you today about the evaluation and management of recurrent seizures in adults with neurodevelopmental disorders. And this is an introduction for primary care physicians. I'm going to take a moment and go over an outline, a review of what we'll be talking about. First, we'll start off with some definition and classification. We'll talk about what seizures are and the fact that they can be divided into partial and generalized types, and there will be some examples of EEG patterns demonstrating partial seizures and generalized seizures. And then we'll discuss neurodevelopmental disorders as the cause of seizures, and there are hundreds, if not thousands, of different neurodevelopmental disorders. For example, Angelman syndrome, Fragile X, Down syndrome, all of which are associated with an increased incidence of seizures. And then we'll get into the clinical evaluation of seizures using physical examination and history and laboratory evaluation. And then we'll touch on some treatments. We're not going to go into a lot of detail about drug treatment, but mainly keep it general and discuss general categories of treatment. And of course, neurologists are always the experts to go to when you are selecting treatments. And then we'll talk about the importance of monitoring of the effectiveness of treatment. So whether it's a neurologist that's directing the treatment or the primary care physician, and regardless of what the treatment is, it's important to monitor whether that treatment is effective. And we use a system of longitudinal graphic analysis. I'm going to give you some examples of longitudinal graphic analysis. So let's get started with some definition and classification. I define a seizure as a sudden onset of uncontrolled brain activity. So it's important to keep in mind that it's something that happens in the brain that is associated with unwanted subjective experience and or observable change of motor behavior, such as tonic-clonic activity. Epilepsy is simply recurring seizures. And seizures can be classified based on their onset. There can be partial onset, meaning that just one part of the brain is experiencing some irritability, and consequently you can see one part of the body may be shaking. The person may be fully alert. There may be no alteration of consciousness, in which case it would be a simple partial seizure. But if there is some alteration of consciousness, but still it's a very localized activity, that would be called a complex partial seizure. If the onset is sudden and severe, starting with a tonic and then clonic activity, or if there's an absence seizure, these are generalized onset seizures. But more often than not, perhaps in people with developmental disabilities, there's a partial onset which is not really appreciated, followed by a secondary generalization. Here's an example of a video EEG. The video EEG is sort of the gold standard for evaluating seizures. And the patient is sitting in a chair there. He's not seizing at the time. You can see where the seizure begins. You see the blue rectangle down there with the arrow. And you can see all of the leads are demonstrating the seizure activity. So whether it's in the frontal or temporal or parietal or occipital, everything is demonstrating seizure activity, and there's an EKG at the very bottom. Now here's a partial onset seizure. You can see that where the blue stars are, those leads are temporal lobe seizures, and you can see that part of the brain is is demonstrating the seizure activity, and that translates to clinically random movements, lip smacking, table pushing, lack of response to verbal directives, but there's no tonic-clonic activity. Now, of course, as time goes on, that can generalize. You can see all of the leads start to demonstrate the seizure activity, and that translates to a change in the clinical appearance as well. Now, what causes recurrent seizures? The cause is dysfunction of the brain that may be caused by hundreds of different genetic or acquired disorders that may develop in childhood or adulthood. And by that I mean everyone who has a seizure has a neurodevelopmental diagnosis, which could explain that seizure. Now, there may be the neurodevelopmental diagnosis plus other conditions that develop, but it's always important to consider the underlying neurodevelopmental diagnosis, and that may be contributing to the seizure. For example, phenylketonuria. If you don't know that the person has phenylketonuria and has developed seizures, and you check the phenylalanine level is very high, and then you put them on a PKU diet, get the phenylalanine level down, that may help the seizures. It may prevent the seizures from occurring. Of course, if there's a brain tumor or some electrolyte imbalance, a number of different causes that could lead to seizures. But consider the underlying neurodevelopmental diagnosis as being contributing, and we're going to go over some examples of neurodevelopmental diagnoses in the next couple of slides. Now, let me define what I mean by a neurodevelopmental disorder. A neurodevelopmental disorder is a genetic or acquired disorder of the brain that first becomes clinically apparent in childhood, and they're associated with measurable biochemical or structural brain abnormalities, and may be associated with four major symptom categories. Cognitive dysfunction, used to be known as mental retardation. Now it's intellectual deficiency, ID. Secondly, there can be motor dysfunction, maybe known as cerebral palsy. And the third is behavioral dyscontrol, which can appear in many different DSM type of psychiatric syndromes, whether it's bipolar or atypical psychosis or anything the psychiatrist can come up with. It may be related to the brain problem that the patient has. And lastly, seizures, which is the topic today. Seizures can be a manifestation of the underlying neurodevelopmental disorder. And the seizures can occur either singly or in various combinations. So a person can have absence, can have partial seizures, can have simple partial, complex partial, can have generalized. So you can have a Lennox-Gastaut syndrome, which I'm not going to be talking about, but you see different types of seizure activity. So it's very hard to treat something like this, but you have to know what you're dealing with. Now, neurodevelopmental disorders can be classified as either genetic or acquired. The genetic types can be subdivided into biochemical. A couple of examples are phenylketonuria, homocystinuria, chromosomal abnormalities such as Down syndrome, Angelman syndrome, structural problems such as tuberous sclerosis and neurofibromatosis type 1 are just a couple of examples of literally hundreds and maybe thousands of different genetic disorders that can lead to seizures. And secondly, acquired types can be subdivided into prenatal, perinatal, and postnatal. The prenatal example, congenital rubella syndrome, fetal alcohol syndrome, perinatal problems such as perinatal hypoxic encephalopathy, postnatally lead poisoning, measles encephalitis, and brain tumor. And we have an example of a brain tumor coming up. These are specific neurodevelopmental disorders. This is a slide of disorders that I've actually had some experience with over the years, so they may show up in your practice. They are many of them are considered rare abnormalities, but they may not be as rare as you think if you consider them. And phenylketonuria, for example, you may diagnose that in adult. And of course, Fragile X syndrome is something to consider. It's not that rare. Tuberous sclerosis. So those are genetic neurodevelopmental disorders. And acquired neurodevelopmental disorders, congenital rubella syndrome, toxoplasmosis, brain tumors listed here, a lot of different conditions. But it's important to know, to try to explain why this person has those four symptom complexes, 1, 2, 3, or all four, as complications of a neurodevelopmental disorder. And so knowing what the underlying neurodevelopmental disorder may play a role in what treatment you select or how you manage the patient. And again, just to repeat that the four major complications of a neurodevelopmental disorder are cognitive dysfunction, motor dysfunction, behavioral dyscontrol, and recurrent seizures. And it's important to point out that seizure is not a neurodevelopmental disorder, but rather a symptom of a neurodevelopmental disorder, just like a cough is a symptom of pneumonia. So you can treat the cough symptomatically, but sometimes it's more effective if you treat the underlying problem, like with an antibiotic, and that would be the pneumonia. Now here's a case example, a nonverbal man with a developmental disability from secondary to prematurity and perinatal infection, who at the age of 45 developed seizures. And this was a severely, what we used to call mentally retarded. I know that term is outdated, but today we refer to that as intellectual disability. But he had a very severe intellectual disability, and at age 45 developed seizures. And initially, multiple drugs were tried, but there was little effect on the seizure frequency. And after a few years, he wasn't really getting any better. In fact, he was developing some new symptoms. Walking was becoming difficult, more ataxic, and he developed impulsive behaviors, temper tantrums. And so he was seen by the neurologist, and an MRI was ordered, and this is what was found. On the left-hand side, this was the initial MRI showed a brain tumor, which was felt to be glioblastoma multiforme because of the rapid growth. By December, like 6 months later, you can see on the right-hand side there a huge tumor, and he really was going downhill rapidly. I'm going to show you just a couple other views of that tumor. The coronal view on the left is taken initially, and then on the right, 6 months later. You can see on the right-hand side, actually it's the left-hand side of the brain, the large tumor, and here the axial view from looking at the top down. The same tumor, two different times. A rapidly growing tumor. And initially, when he developed seizures, it was not felt to be a big deal. He was, mentally retarded, profoundly intellectually disabled, and they get seizures as they get older. So it was just felt to be kind of typical of the mental retardation, which this is a phenomenon called diagnostic overshadowing, which has been used to that, where every new symptom the person gets is related to their MR, as used to be called. Now it's ID. I'm not sure what it'll be called 10 years from now, but it's the focus on the cognitive dysfunction. You have to think of that this is actually a physical problem, and that there may be multiple causes. So in the initial evaluation of seizures, there are 3 steps. First, a careful description of the observable motor behavior and or the patient's subjective experience, if possible, if the person is verbal, so that the physician and the neurologist can really understand that this is indeed a seizure. Does it really sound like a seizure? Because the treating physician may not have ever witnessed this, so you rely on family or staff to describe that, and sometimes it turns out that it was not a seizure, but yet the staff will tell you, well, the person had 10 seizures this month, but with careful evaluation you find out it's not really seizures. So it's very important if the physician or neurologist could actually get a little video of the event, that would help sometimes, if that's at all possible. So step 2, documentation of the uncontrolled brain activity that underlies the motor behavior. So you want an EEG normally. There are other ways you can approach that, but practically speaking, we use the EEG. And the video EEG is the gold standard, as I mentioned. That's the best way to do it. And then the step 3 is the diagnosis of the underlying neurodevelopmental disorder that's responsible for the seizures. So you try to look for a cause. Now, you don't always find something. It remains idiopathic. It could have been the birth injury. Who knows? But it's important to look for an explanation, because again, as I mentioned, the seizure is a symptom of an underlying problem. So if you can discover what the underlying problem is, it may help you manage the patient more effectively. Now, the treatment of the seizure, of course, depends on the diagnosis of the neurodevelopmental disorder and on the type of seizure. So if it's a partial seizure or a generalized seizure, depending on what type it is, some drugs work better than others. For example, Zerontin works better for absence. They say that Depakote is effective for all types of seizures. But you have to talk to the neurologist and see what the latest drug is and what the claims are. And this is a rapidly changing, field, and there are new drugs coming out all the time. I don't mention any drugs here at this point, and I have no recommendations for one being better than the other. I don't think that there are any drugs that have been found to be more effective in controlling seizures than Dilantin, but yet Dilantin is not used much anymore. The newer drugs, the benefit is the fewer side effects. Dilantin can have bad side effects, but we don't have the years and years and years of experience with the newer drugs that we have with Dilantin. So who knows what kind of side effects will be showing up with the new drugs. Things take time. Treatment modalities, anti-epileptic medication, neurosurgery, ketogenic diet, which is used in pediatrics. I don't know of anyone that uses this in the adult population, but it may be something to consider. And then lastly, the vagal nerve stimulator, which is a new thing, and some people believe it's very effective. I'm not really sure myself. I'll have a couple more comments about this later in the talk. Okay, when do you consider the vagal nerve stimulator in persons with epilepsy? Let me mention the 47-13-4% rule here. We're talking about refractory epilepsy. How do we define that? What do we mean by refractory epilepsy? And the 47-13-4% rule, I'm talking about the work of Kwan and Brody, a couple of neurologists that have studied refractory epilepsy, and they have shown that if you use a single drug a single seizure drug to treat epilepsy, that 47% will respond to that single drug. That means that a little over half, or 53%, would not respond. Now, if you add a second drug, then you will pick up an additional 13% with the second drug or a drug combination. If you add a third drug, either singly or in combination, you'll pick up another 4%. So it's a diminishing return. The more drugs you add, the less likely it's going to work. So there are no drugs past 3 that if you get up to 4, 5, 6 drugs, you're not going to get any additional benefit, and you'll get more drug toxicity. So what do you do in this situation? You end up with 36% remain refractory to drugs. So at that point, after you, in my opinion, after you've tried 3 anti-epileptic medications for at least a year, either singly, one at a time, or in various combinations, but you've gone through 3 different drugs, and the person with childhood onset brain dysfunction secondary to a neurodevelopmental disorder continues to have at least 4 seizures a year, an attempt to control seizures with vagal nerve stimulation should be considered. In other words, talk it over with a neurologist. This person appears to be refractory to drugs. I mean, you could try a 4th, 5th, 6th drugs, but again, based on the work of Kwan and Brody, it's very unlikely that you're going to get additional benefit. Now, the claim is, and Dr. Huff has done a lot of work with this, and the claim has been that you can get better seizure control, but also improve cognition, improve mood, behavior, weight control, reduce drug toxicity, and you're able to reduce the number and dosage of the anti-epileptic drugs. I'm not 100% convinced that you can see all these benefits in this population, but it's something you should consider and think about it. There needs to be more research on this in people with severe developmental disabilities, but it may work. It may work, but time will tell. Now, there's some special problems encountered in patients with neurodevelopmental disorders. First of all, they have multiple brain lesions and seizure foci that may lead to a variety of clinical presentations. The recording of seizures is more complicated, and the efficacy of treatment is more difficult to determine. And this last thing, I think it's so important to determine efficacy of treatment, because so many people with severe cognitive dysfunction end up on multiple seizure drugs, which have a lot of side effects. There's polypharmacy, and it's not real clear whether they're getting any benefit from all of these drugs. And it takes a lot of determination to try to determine efficacy, and so the person remains on the fewest possible drugs. I think it's a very important principle. Okay, it's very important to document the efficacy of treatment, as I mentioned. This includes a careful description of the seizure, determination of an adequate baseline frequency, then beginning treatment, and then continue to document the response to treatment using a system that we call longitudinal graphic analysis, and I'm going to give you an example on the next slide. Okay, this is a graph of longitudinal graphic analysis, an example, and you can see that this person was on Dilantin and Lamictal. The Dilantin was started many years before this graph was started, and the seizure frequency beginning in January was 20 times per month, and you can see there's an up and down here. The seizure frequency goes from almost 25 at one point in May. It goes up to 27 and then down. So there's some up and down frequency of the seizure on the red line there. And then in actually in August, the Lamictal was started, and you can see that the Lamictal in the blue line was increased up to 200 milligrams per month. And it looks like the seizure frequency has decreased significantly. There was no change in the Dilantin level for the duration of this analysis. So time will tell whether the seizure frequency will stay down, but it looks like the Lamictal was effective. And this is a simple example of longitudinal graphic analysis. Okay, here is an example of longitudinal graphic analysis. This is a real case, person on multiple drugs. And if you will just follow the blue diamonds there, the blue diamonds represent the seizures, the seizure frequency you see in the red line name there, seizure, with the arrow pointing to the blue diamonds. And you can see the seizure frequency varies between 1 and 5 times per month. It went up to like 12 back in January of 1998. But you can see towards the end of that slide where the blue star is that the seizure frequency has come down to about 2 times per month, 0 to 2 times per month. And the question is why? What caused that improvement? It looks like probably the zonogran, which is on 300 milligrams per day, was increased up to 400 milligrams per day at the end. But also the Ativan was increased, and the Lamictal was also increased. But it's important to do one thing at a time, really. It's kind of hard to tell, but time will tell whether that combination actually improved the frequency of the seizures. So this is kind of a complicated case, and it takes a little getting used to. This is kind of like reading an EKG. It takes practice, but it's very useful. Okay, here this is another example. Here you can see the Lamictal. The person had been on Lamictal in the yellow line there since 1998, and with Tegretol. And you see the point where the seizure frequency is the lowest is around October of 2002 to like April of 2003. You can see it's the lowest with the Lamictal and the Tegretol. And then what was decided was to try to get him off the Tegretol. So you can see the Tegretol was rapidly decreased and the Lamictal was increased, and the seizure frequency went up, which in my experience is pretty typical. You have to go very, very slow when you taper somebody off a seizure drug. Even though you add a new drug, it takes time to adjust to that, and the drug is not immediately effective. It may take months, so you need a very slow taper. So there are a number of principles here, and you can see the variation in the frequency of the seizures. And it looks like this is a difficult thing to do, but it's not really. Once you establish the graph, monthly you enter a couple of data points, and you just keep this as a medical record, and it's very valuable to any treating physician to have something like this. And here's Lamictal, Myceline, and Tegretol combination. Again, you can see the high frequency of the seizures, the blue diamonds, from the get-go. And the person's on Myceline and Tegretol, and the decision was made to do a switchover between the tegretol and the lamictal, so the lamictal was increased and the tegretol was reduced, and once again you see the increased seizure frequency, probably from tapering the tegretol too quickly. But it looks like at the end there you see the tegretol was restarted, and it looks like the seizure frequency might be coming down at the very end in September of '06. Of course, carbitrol, which is almost the same as tegretol, was used. The feeling was it is less likely to cause hyponatremia, but I don't know whether that's true. But anyhow, the point here is to sit down and analyze these graphs, just like you're reading an EKG. You study the rhythm pattern and you try to get as much out of it as you can. But this is a very useful tool for the primary care physician who is prescribing the drugs and is really responsible for the efficacy with input from the neurologist. And here's one more. I think this may be maybe I got one or two more. Look at all the drugs. I mean, the point here is that so many drugs are tried. It's not really clear whether anything has worked. So these are very complicated cases, and the neurologist, I would just caution them to go slow, do one thing at a time. But you may end up in a situation with real intractable epilepsy, and there's no drug that's going to work. So whether they're on it or off it, they're still going to have the seizures. So what do you do? Okay, here's one more showing the use of a lot of drugs, and it's not really clear that anything is working that well. And this person actually even had a VNS that didn't help. And lastly, this is a person who was taking Klonopin, Tegretol, and Depakote for seizures, and the vagal nerve stimulator was placed in August of 2003. You can see the baseline frequency is a very short period that the seizure frequency was counted, but it was about 27, 28 seizures per month, and at the end there it's down to around 10 per month, and it looks like, and the drugs were not changed during this time period. So it looks like the effect is from the vagal nerve stimulator, which was adjusted by the neurologist, seemed to have some efficacy on the seizure frequency. Okay. So in conclusion, seizures are very common in adults with developmental disabilities. An attempt to determine the cause should be considered. If the cause is determined, the treatment may be based in part on treating the underlying cause. For example, phenylketonuria, drug toxicity, brain tumor, vitamin D, calcium deficiency, electrolyte imbalance can all contribute to seizure frequency. And there are other approaches, including surgical treatments and drug treatments. But regardless of the treatments chosen, efficacy of that treatment should always be documented. Okay, that's it. Thanks for listening. If you have any questions or would like to make any comments, send me an email at ifcd.pmay@gmail.com. Bye-bye.